and welcome. I'm Marcia Mott, coordinator for the UF Health Wellness University. Thank you for joining us today as we learn about what's new in joint replacement. I'd like to introduce you to our speaker, Dr. Chancellor Gray. Dr. Gray is an associate professor with the University of Florida Department of Orthopaedics. He joined UF Health in 2015. He sees patients in both Gainesville and Summerfield near the villages. If you have any questions for Dr. Gray, you can submit written questions at any time using the Q&A button at the bottom of the screen. At the end of the presentation, I'll read your question anonymously. I will only be accepting written questions, and I will try to get through as many questions as possible. So there's no need to raise your hand, just simply type your question in the Q&A box at the bottom. Dr. Gray, I'm going to go ahead and turn over to you now. Thank you.
Thanks so much, Marcia, and it's a privilege to be able to speak with everybody today. So thank you all for joining. Let me get my screen here. Okay, so as Marcia mentioned, I'm going to be talking about what I see as big improvements in the last several years in hip and knee replacement surgery. And I just want to take a minute and introduce myself a little bit. Some of you on the call may know me, but I'm sure most don't. So my name is Chance Gray. I am actually initially from Pittsburgh, Pennsylvania, but I used to spend a lot of time in Florida. Every year I came with my family to Vero Beach. It was a vacation spot for us, leaving Pittsburgh. And so Florida was a place that I had a lot of love for. And then ultimately I married a girl with Gator blood and we moved to Gainesville. So my wife was born here in Gainesville. And obviously we chose to relocate here about 5 years ago when it was time to start our medical careers. And we've started a family here and have really enjoyed being in Gainesville. As Marcia mentioned, I'm a hip and knee replacement specialist, and I'll tell you a little bit more about what that means. So my practice here at the university is exclusively hip and knee replacement. As an orthopedic surgeon, I specialize just in hip and knee. And that divides between what we call primary hip and knee replacement, which is first-time surgery when you come to me with arthritis and we do a joint replacement, versus about 30% of my practice, which is what we call complex revision hip and knee replacement. So those are people who, for whatever reason, have failed a total hip or total knee replacement done elsewhere, or who have infections or other problems, chronic pain in their replaced joints, and we see those patients. And that represents about 30% of the surgery I do. I'm a member of both the American Association of Hip and Knee Surgeons as well as the American Academy of Orthopedic Surgeons, which are two sort of governing bodies that certify us and give advice and sort of oversee joint replacement care in the United States. And I'm a fellow member of both. So just to tell you a little bit about what else I do at UF, as UF is an academic medical center, excuse me, I teach both residents and fellows and also medical students and even pre-medical students. And I have the role of associate professor. I also have the privilege to be one of the physician directors of quality here. And what that means is I oversee a lot of the quality improvement programs that we do. So when we recognize deficiencies in care, opportunities to improve care, I'm the one that oversees those for the Department of Orthopaedics, primarily focused on the inpatient side, meaning people who are going through surgery in the hospital. And then I also am the co-chair of the Patient and Family-Centered Care Program, which we've run here for several years. And which has a major role in looking at quality of care for joint replacement patients. And I'll touch more on that momentarily. So my philosophy with joint replacement is that I think that it's really important. Your main goal when you come to see me is to get back to leading a really active and I think happy goes side by side with that. If you can't be active, it's hard to be happy. So I want to get you back to leading the quality of life that you've envisioned for yourself as you get into your, ideally your retirement years, but I have many patients who are much younger than that. But if for whatever reason you're no longer able to be active and it's because of your hip or knee, my goal is to get you back to activity. I try and look at surgery as a last resort. There are some patients for whom we know right away we need to go to surgery, but many of my patients are trying to avoid surgery and we want to work with them to do that. My goals are not to operate on you, but just to get you back to activity. And many times we can avoid surgery. My other goal, and I think this is important to touch on, is that I really look at myself as your best doctor. I don't want to just be your operative surgeon, and then sort of forget about you. I want to really take good care of you and help you with, help you get connected into other health issues you may need attention for. And even if they're things I can't manage, but help you get plugged in to folks here who can. And I really do care about both your short and your long-term outcomes. So I don't want to just focus on the time right around surgery or the time you're in my office, but really how you do over the long run, ideally for 20, 30 years. So for those of you in the audience who are thinking, well, I know I've been told I have arthritis. Do I need a joint replacement? And here's a hip replacement and a knee replacement side by side, and this is what they look like, and I'll show you a little bit more about them later. But the simple answer to that is maybe, maybe not. Many patients that I see do very well, whether or not they get surgery, and thankfully most patients that do get surgery do very well. Surgery is very safe, it gives lasting pain relief, and obviously improvement in function. And most of my patients return to many, and not necessarily all, but most of their activities that they wanted to get back to. And I'll touch more on that in a bit. But there are disadvantages, and this is why we don't jump right into surgery for everybody. Number one, it's surgery, and surgery is not without risk. I mean, surgery is at risk for your heart, your brain, your whole body. It's a big thing to go through, and so we do take that very seriously. And it comes with the risks of a major operation, getting anesthesia, all those things. One other thing that's unique to joint replacement: once you have a joint replaced, you've bought that for life. There is no undoing a joint replacement. So once you take out your bone and cartilage and trade it in for metal and plastic, it's yours. There's no way to undo it. And so I think that's important for patients to recognize, and for us to recognize as surgeons, that this is a lifelong decision. And of course, with that, if there are problems in the future, you may need further surgery. And thankfully, that doesn't happen often. But as I said, about 30% of my patients are people who have had a failed joint replacement from somewhere else. So there are these times when surgery does go wrong. And so these are disadvantages, and that's why we try and hold off when possible. So if you're trying to think of how you can guarantee for yourself the best outcome, I think there's a few things that are really important. One is you want to pick a high volume center that has a track record of excellence. That's been demonstrated time and time again in the medical literature, that going to a place where you have a high volume of these operations really does help ensure a good outcome. And then secondly, it's important to have a high volume surgeon with the same track record. And there's clear evidence that people who do a lot of these operations do them well, and people who do less don't necessarily do them as well. And that just reflects that practice and experience really make a huge difference here. When we're talking about outcomes, there are different rates of infection, early revision, and readmission that can vary by huge amounts from surgeon to surgeon and from center to center. And so that's why that stuff matters a lot for you. One other thing that I think is important to talk about is, it's important to avoid fads, marketing pressures, and what I call sort of modern day snake oil. Unfortunately, as much as we pride ourselves on really doing evidence-based practice, there are ways that you can get into trouble with fads and modern day snake oil. So and I can speak a little bit more to that later if there's time about what in particular I'm talking about, but we want to really stick with things that are tried and true and that we know give the best possible outcomes. So when people say, well, okay, great, where do I go and how do I do that? I think this is where University of Florida really shines, because we meet those criteria that I mentioned. And I'll try and tell you a little bit about why I think we do that very well here. So as I'm sure you've seen the signs, or if you visited the UF Health webpage, you've seen this, but UF Health Shands Hospital was just ranked the best hospital in Florida and among the nation's best in a bunch of different specialties this summer when US News did their annual rankings. And we were ranked in the top in orthopedics, and in particular, we were recognized as a high-performing hospital in hip replacement and knee replacement. And we have had many other awards and recognition from national programs in our joint replacement program. So, as I mentioned, we were just recognized as the U.S. News highest category. Medicare has designated us in their highest quality category. Out of 5 different distinctions, we're in the top level. We were recognized by CMS, which is another part of Medicare, as a best practice site for the way we handle opioids, as well as infection, perioperative infection. We've won multiple awards in our division from UF Health for the quality of care we deliver And we've actually given webinars to other centers around the country to inform them on how we practice here. Institute for Healthcare Improvement, which is a national organization, has recognized us with quality awards as well. So thankfully, UF Health has really been able to distinguish itself as a top tier provider for hip and knee replacement. So when we were looking at how to really idealize patient care and modernize patient care, we looked at, we tried to focus on what was really important to patients and their families. And this is how we started the UF Patient and Family Centered Care Program. So we thought about things that were most important. We wanted to focus on an ideal hospital and clinical experience, very technically advanced surgery, and then in the long run, having a long-lasting and pain-free joint, not just a short-term outcome, but a good long-term outcome as well. And I'll talk more on these things in a bit too, but these are some of the things that are really, I think, new and important in total joint surgery. And these first two things are kind of grouped together. Enhanced recovery programs and outpatient surgery. I'm sure many of you who have had a prior joint replacement or know a parent or somebody who had a joint replacement many years ago are fairly surprised that we do a lot of our surgery now on the outpatient basis, meaning you come into the hospital and you go home the same day. Actually, about half of my patients now are going home on the same day, and that's been facilitated by a lot of different things that have helped people have an early, faster recovery. And I think that speaks to how much more effective we are at keeping people comfortable, minimizing the trauma of surgery, and really getting people moving. Two things that I've sort of focused on. One is tourniquet-free total knee replacement. So by not using a tourniquet, we have less damage to the muscle, less time where the muscle is not getting blood flow, and a faster recovery for knee replacement, and then also muscle-sparing hip replacement that I'll talk more about in a bit. So when we were looking at how to really enhance the experience, we thought, how can we make this ideal? How do we enhance recovery? And how do we ensure best long-term outcomes? Well, we began by saying, well, what would I want for myself or my own family members? And these things were important to us and we thought would be important to our patients. We wanted to emphasize clear and consistent communication from all the members of the team. Hopefully have a short wait time from the time you call us and say you want to come see us. Not be told, well, you can't come into the clinic for 6 weeks, but to be able to make a soon appointment. And then ideally, if you need surgery, to get into surgery soon. We wanted our patients to really know that we were invested in them, and not just me, the surgeon, but the whole team. We wanted you to feel like the center of attention. And then, you know, this is a really important one. We didn't want there to be anything that you didn't quite get or didn't understand, or things that happened that you just said, well, why is this happening to me? We wanted to have really good patient education and engagement. And we recognized with enhanced recovery, especially, that recovery begins before surgery. So what are the things that we could do to help enhance people's surgical experience ahead of time and then during surgery? And so we start with multimodal pain management, which is a way to avoid narcotics. Regional anesthesia also helps with that and avoids the need for as much general anesthetic, although we still have to use some general anesthesia in many cases, but minimizing that. And then being, again, really friendly to the tissues around the hip and the knee so that people can actually get up and get moving. We use twice-a-day physical therapy. So if you come in and have surgery in the morning, you'll probably have 2 PT sessions that day if you spend the night with us. You'll at least have 1 or 2 before you go home if you don't spend the night if you go home. And minimizing transfusions is really important. Many people used to give blood ahead of time before surgery and then get that own blood back. Well, now we found out with a few tricks that we can really avoid transfusing the vast majority of our patients. 99% of our patients do not need a transfusion, which is a big change. And when we look at long-term outcomes, the things that really have been shown to work the best, you know, using tried and true implants, not brand new things that have just come out that the implant company is saying, oh, this is going to be the best new thing. And then a couple of years later, it's recalled, but using things that we've really established as great performers. And then same thing with surgical techniques that are safe and effective and have good evidence. And one other thing we do, and this is really important, we are constantly assessing, is what we're doing working? Did we, you know, have we proven that if we change something that it was a good change? Can we modify something if needed? And we get a lot of feedback from our teams and our patients, and we keep checking and rechecking. So we did this, as I mentioned, largely through our PFCC program, which is that Patient Family Centered Care Program. And that's something that's really unique to UF. There's only a few centers in the country that have one of these programs. And we are, to my knowledge, the only one in Florida. But this program was really helpful. We brought in a lot of different team members. So this isn't just the surgeons, this is the anesthesiologists, our nurses, our physical therapists, all these people that are interfacing with our patients, giving feedback and saying, hey, this is what's working, this is what's not working, getting together regularly. And then regularly talking about what our various victories have been and what our various concerns have been. And that really facilitates that iterative improvement. We also hired a nurse navigator, and this is somebody who is sort of your first touch point through the operation. You meet her ahead of surgery and you have her number and you have access to text her questions or send pictures if you're worried about something or your home nurse is worried about something. So it's a really good way to have constant contact with our team. And she is a really effective liaison between the patients and the surgeon. And she can troubleshoot a lot of things herself, and things she can't, she quickly can bump up to us. But this has been a real asset for our patients. We also started a really robust education program, and this used to be run right here in our orthopedic building. Right now with COVID during the pandemic, we are not bringing people into the building for this class, but we are actually building an online class that people will be able to watch and share with their friends and family if they want to. And that should be going live shortly, but it helps avoid a lot of these surprises or these unexplained interventions. And we believe strongly that better education improves outcomes. I mentioned that we want to be constantly checking our progress, and so we actually use a joint scorecard that we built with our informatics department, so we can look and see what things that we're doing are working well and what things are not. How can we continue to improve outcomes using that scorecard? So as I mentioned, all this is very patient-centered, and I just want to share a few of these major pathway changes that have happened over the last few years that are really this leading edge. And again, I want to emphasize that all these things have been multidisciplinary and had many components. So this was not just us doing this. This was us bringing a whole team together and doing these things that we think really helped improve care for our patients. So many patients wanted to be home after surgery. A lot of patients historically have gone to rehab facilities after surgery. Well, it turns out that's actually not good for you. You're better off being at home. And so when we began to focus on this in late 2016 or mid 2016, you can see that, historically we were sending maybe 30% of our patients to a rehab facility. And by late 2017, we had gotten that to almost, less than 10%, pretty characteristically. So that was a big improvement for patients. I mentioned the joint replacement education program. This is our website that you can see on the right side of your screen there. And we have a series of really excellent videos that are available now, and we're adding to that, as I mentioned. But this is something that you can link to, and I'm sure Marcia will be able to share this slide deck with you all after this talk. And you can see there, it's got the web address, so you can go on and look at many of these videos and begin educating yourself about our joint replacement program. We created what we call a clinical practice guideline for risk stratification. So we actually have about 30 different categories of medical problems that we say, okay, if you're in the green category, we're going to proceed with surgery. If you're in the yellow category, we may need to optimize some of this, with a high blood pressure. Is your blood pressure under good control? Do we need to have you get in with your primary care doctor and work on that? Or do we have some red situation where we really can't take you to the operating room soon, and we need to make some big moves to help you get into a better risk category? And we did this for many different categories. And that really helped avoid many of the common complications that people have after joint replacement surgery. We also created a unified practice approach to many of the questions that our physical therapists and nurses were having post-operatively. So rather than having 7 or 8 different surgeons all doing different things, now everybody's on the same page about what are the important things we want to look out for, when can people shower, things like that. We got everybody all doing the same thing, which really made things easier for our teammates. I mentioned the nurse navigator and how she really can help facilitate all these different communications and handle things very well. When I'm in the operating room, Amanda, our nurse navigator, can be available to you. So if I'm operating on somebody and can't answer your question, she's available to you if you have a pressing issue. We've used our electronic medical record very well, and this has helped us actually have a really good way to reach out to people. This tells our team who they need to call, who is at a certain stage in their recovery, who's 2 weeks and needs a phone call to check on their incision. This just gives a really easy dashboard for our team to reach out to you and really enhance their ability to make contact with you and make sure that nobody is slipping through the cracks. One other thing that I think was really helpful is we've basically given you 7-day access to our team. So between ortho care after hours and our clinic schedule, one of us or at least an orthopedic surgeon are available in the orthopedic clinic 7 days a week, and that includes Saturday and Sunday. So, you know, for those of you who say you have surgery on a Thursday and you get home and things are going well, and then on Sunday all of a sudden you're worried about something, you don't have to worry about waiting until Monday or Tuesday to come and see the doctor. You can actually come Sunday afternoon and come and be seen by an orthopedist in our building. And I think that's been a huge asset for people, helps people keep out of the ER if they're worried about something. And thankfully, most things end up being, you know, not a big deal, but this is an easy way for us to be able to triage that and give our patients good access to it. So this was a big improvement. We created the opportunity for same-day physical therapy in the recovery room. We have a physical therapist who is stationed in the recovery room. That's one of my patients who is just about an hour out from his knee replacement, and he's up and walking. You can see he's wearing that brace to help protect his knee, but this is a little pain pump that he's got that's giving numbing anesthesia into the front of the leg. So he's actually comfortable enough just an hour after a total knee replacement to be up and walking on that knee. And so that really helps avoid a lot of complications like blood clots, urinary retention, pneumonias, things that happen when we stay still. From this, we built a really strong outpatient program. So we've been doing outpatient surgery now for about actually almost 4 years now. And it's now, you know, over 35% of our cases. And amazingly, outpatient surgery where you go home same day leads to, this is something we published, leads to lower readmissions and lower complications. If you look in the bottom right there, you can see that our outpatients had less than a 1% readmission rate at 90 days compared to the people who stayed in the hospital who had about a 3%. And both of these numbers are better than national average. But believe it or not, going home is actually really good for you. And going home quickly is really good for you. This just shows a handful of publications that our center has done on all these sort of quality culture that we've created here, you know, the outpatient program, things that we've done to reduce readmissions, things we've done to create scorecards to help people better manage joint patients. So I'll talk now for a little bit about how I do a joint replacement and some of these new things I mentioned earlier. Before I do that, I wanted to take a moment and share 2 videos. These are both short videos, they're about 90 seconds each, that actually show you what a joint replacement looks like, so you know a little bit more as we talk about this. And so let me start with the first one here. This should queue up.
Total knee arthroplasty or replacement is a surgical procedure in which a disease...
Dr. Gray, we don't see it, we only hear it.
...placed with an artificial
Okay, one
joint.
second, I'm sorry.
Your knee is made up of the lower...
I think you have to stop your PowerPoint share and switch over to whatever your internet browser is where the video is. There we go. Now we see it.
Okay.
End of your thigh bone or femur, the upper end of the shin bone or tibia, and the kneecap or patella. Most replacement joints consist of a metal femoral component, a plastic tibial component held in a metal tray, and a plastic patellar component. The procedure begins with an incision on the front of the knee, and the kneecap is moved to the side. Damaged bone and cartilage at the end of the femur are cut away, and the bone is measured and cut to fit into the femoral component, which is then attached. Next, damaged bone and cartilage at the top of the tibia are cut away, and the bone is measured and cut to fit into the tibial component. A metal tray is fit against the flat cut top of the bone with its stem inserted into the bone. A plastic insert is snapped into the tibial tray. The femoral component slides on it when the knee is bent. The damaged portion of the kneecap may be replaced by a mushroom-shaped prosthesis. The resectioned patella and prosthesis are attached to other components. Measurements and tests to ensure balance and movement are done during and after surgery. Knee replacement can significantly reduce pain and improve function. Like all surgery, there are associated risks. Physical therapy and realistic expectations are important for successful recovery.
Okay, great. Let me get the other video one moment here.
Total hip arthroplasty, also called total hip.
Is this video showing on the screen?
Yes, we see it just fine.
Great.
Replacement begins with an incision to allow access to the bones of the hip joint. The next step is to remove damaged cartilage and bone from the acetabulum, the cup-shaped hollow in the pelvic bone. This damage results from the bones rubbing directly against each other when protective cartilage wears away. A tool called a reamer is used to prepare the acetabulum to receive the socket portion of the hip replacement. This metal and plastic combination is called the acetabular component and is fitted into the newly reamed bone surface. The outer metal part of this component, sometimes called a cup, fits directly into the socket. The inner plastic portion has a hollow to hold the replacement for the ball-shaped bone at the top of the thigh bone or femur. The outer metal part is rough to help bone grow into its surface over time to lock the artificial socket in place. The next step is removing the ball-shaped head of the femur or thigh bone and preparing the femur for placement of the stem portion of the component. A metal ball is attached to the end of the stem and fits into the artificial socket in the hip bone. Together, these components replace the natural ball and socket joint. During and after surgery, the surgeon verifies the correct fit and range of motion of the hip replacement components. By mimicking the anatomy and functioning of the natural hip joint, hip replacement can reduce pain and permit a return to many activities.
Okay, let me just go back to my PowerPoint here. So I think those videos are helpful because they give you a good basic understanding, and I can tell you a little bit more now about how I sort of customize those techniques. So with a hip in particular, there are really three ways to get into the hip joint, and that video that was just done showed a lateral positioning, and you can do either a posterior or a lateral approach from that position. Posterior is probably the most common way hip replacement is done in this country at this point. I'd say about half of hip replacements are done that way. The lateral approach is the traditional technique that was done many years ago and still has some role. But the way I do most of my hips right now is through this anterior approach. And this is a newer technique. It's actually been around since the 1970s, but was really, I think, idealized in the 1990s and early 2000s and has gained a lot of attention in the last decade because it's muscle sparing and helps people have an earlier recovery. And so I do most of my operations through that approach. And each of these approaches has risks and benefits. There are some reasons why one might be better for you than the other. And so what I always tell patients is that even though we think in most patients, all things being equal, the anterior approach has advantages, there are certain times when we may want to do a different one. And so we want to talk with our patients about what the pluses and minuses are with each of these and make sure we pick the approach best suited to you. Okay, so as I mentioned, some are better for some patients and than others. And about at this point, most of my hips, as I said, are direct anterior, so about 75%, and then a mix of lateral or posterior for the other 25%. That number is probably a little less now. I'm probably about 80 to 85% anterior. And as I mentioned, it depends on several different patient-specific factors. For knees, what I typically do is what I call a medial curvilinear approach. And that's a little different than what you've probably seen if you have a friend or a family member that had a knee replacement. Typically, you would see this big straight line incision over the front of the knee. And I've actually found this, this curved incision over the medial side of the knee to be a little more favorable. And I'll show you what it looks like in just a moment. I like it because I think it does help have a little less pain when you kneel. It's a more favorable cosmetic scar. And then, as I talked about earlier, I've moved to doing almost entirely tourniquet-free or very limited tourniquet. And the tourniquet is something many surgeons use on the knee because it helps minimize bleeding during surgery. And it helps the surgeon have a very clean surgical site. But unfortunately, it can lead to an hour and a half of time where the muscle around the knee joint is just not getting any blood flow. And I think that's not the best way to go through a surgery. It's better if your muscle can be getting blood flow all that time. And so we've moved, and a lot of other surgeons are doing this now as well, but this has been a big change, I'd say, in the last 5 to 10 years, is switching to this really limited use of the tourniquet so that people can have a little earlier return of their function of their muscle. Many patients ask about the lateral approach, which is something that's unique in the state of Florida, and I don't personally like that approach. I'm happy to talk more about that later if time permits and if people have questions about that. But that's something that I would group in the category of a bit of a fad, not evidence-based, and I'll touch on that later. So this is one of my patients who had a knee replacement, and her knee replacement is about a year old now, but you can see that curved scar curves just to the inside of the kneecap. Her kneecap's right about here. And when the knee is out straight, that scar is only a couple inches long. When the knee is bent, it almost disappears. It's hard to even see that she had her knee replaced, if somebody was just looking at her at a glance. And so I think that scar really helps when she kneels. If she kneels for any reason, she's not kneeling right down on that scar. Her kneecap is over here. And so it helps people have a little easier time, in my opinion, with their knee surgery. We do our anesthesia one of two ways, either through a spinal or what's called total intravenous anesthesia, which is a variation on general anesthesia. Each has, again, as with everything else, there are pluses and minuses to both. So the single shot spinal avoids a tube in your throat. During COVID, we've particularly liked that. We think that having patients breathing on their own probably helps for a lot of reasons. But even with the spinal, you can either choose to be fully awake or fully asleep. But the nice thing is you're breathing on your own. And then with total intravenous anesthesia, there is some suggestion that people who have this kind of anesthesia actually can maybe start walking a little sooner and have a little lower risk of urinary retention. Although I think we've changed our spinals a bit, especially in the last 6 months, to help minimize those risks of waiting to walk and with urinary retention. But both of these are very good options, and we use both about half and half, and they work very nicely for our patients. The surgery takes me about an hour, depending on how much work we have to do. If there's a lot more damage than somebody else, it may take a little longer. But as I mentioned earlier, the goal is to walk later that day. And many of my patients, about 60% of my patients now, our group is about 35%. For me, is about 60% of my patients are going home same day. And the rest go home somewhere in either the next day or the early part of the day after. My patients can shower once they get home. They have a waterproof bandage on, so they can actually sort of feel a bit more like themselves. Get home, get some home cooking, sleep in their own bed, get a shower. It's a really nice way to go through a joint replacement rather than be in the hospital for a few days. Both my hips and my knees, I have no motion restrictions after surgery for the vast majority. There are rare exceptions where that's not true. We let people do full weight bearing right away. And we discharge to home as soon as we can. As I said, most on day of surgery, post-op day 1. And then the goal is to get you back to your activities at the earliest possible time. Most of my patients can be driving by about 2 weeks out from surgery, and I give you a full release from my sort of restrictions, if there are any, by 6 weeks. And typically the only thing that's still in place at that time is that I don't want people to swim or be in a bathtub submerged until 6 weeks. As I said, we let people shower right away, but no swimming or going in the ocean or anything until 6 weeks to allow the skin to fully heal. We like home recovery because it's better, faster, and safer. Honestly, you do need somebody to be there with you. It's really hard to do this on your own. We have some patients that do it, but I wouldn't recommend it routinely for most of my patients. And really, when it comes to therapy and the recovery, for hips, your most important thing you need to do is walk. If you can walk with a walker at home and with your spouse or a friend or a neighbor or a sibling, you may not even need physical therapy. We still do get you a physical therapist, but many of my patients don't need them. And then for knees, we often recommend outpatient PT or home-based PT, and that's just to help get range of motion. Knees get stiff. Hips don't get stiff, knees can. And so that's why we emphasize that. Most of my patients are back to doing many of these activities, golfing, swimming, et cetera, shortly after surgery. So most of my patients use a walker for 1 to 2 weeks, particularly after hip replacement, probably closer to 1 week. And then a cane for maybe an additional week. So hopefully by 2 to 3 weeks out from surgery, you're not using any gait aids. And sometimes the cane's not needed. Some of my patients are off the walker and off the cane by 3 or 4 days out from surgery. It just depends a little bit on how strong your muscle is going into surgery and how quickly you bounce back, based on how severe your arthritis was. And again, these are approximate times. Most of my patients are starting to drive around 2 weeks. By 6 weeks, the soft tissue is very well healed, and that's why I give that sort of full release and really allow you to do anything you feel up to. People ask me, what can I do and what can't I do? And I really tell patients they can do what they want. We do recommend not doing high impact activities, but those are things like running, jumping. But in terms of being able to get back to most things people want to do, they're really doing that again, not too far out from surgery. So I wanted to share a couple of videos. These are 2 of my patients. I'll start with this one on the left. This is, she's about a month out from surgery. She had her hip replaced. And you can see how she's walking in the office. Obviously no cane, no walker, she's not limping, very comfortable. This is another patient, and she's actually just 2 weeks out from surgery from a hip replacement. And you can see she's very proud of how far she's come along. So these are fairly typical results for our hip replacement patients, and our knees actually probably even do just as well. I just don't have any videos of those, but those are 2 patients for their first visits after surgery, both showing how well they can walk shortly afterwards. Here's another one of my patients who is very proud. He's got his official hippie t-shirt on. He's 100% authentic new bionic hip. And he wanted this picture with me because he was really proud. He got his tie-dye shirt, and this is him at just a month out from surgery. So again, no cane, nothing. He's standing right there next to me. He's really pleased with his recovery. Now he's a little bit younger than many of my patients, but was doing very well. So I have a couple patient examples I can go through here, and then we'll be done and we can take questions. The first is a patient, her initials GL, she was 63. She's in good health, thankfully. She lives with her husband, she's retired. She's been having this prolonged period of this left-sided pain that's kind of focused around the lower back, her buttock, and her groin. She had initially thought that she was having a back strain, and she tried a bunch of different things before she got sent to see me. She had actually tried stem cell treatment, which didn't work. She'd tried prolonged PT, and she'd actually been on pain medicine for over a year that were started by her primary care doctor trying to help her out. But the pain medicine was making her feel tired and groggy, and she was constipated, and she was just pretty unhappy and having a hard time getting to the bottom of this. And so when I got to see her, these were her x-rays, and you can see here her hip on the left side compared to the right has no cartilage left. So this hip on the right side here, and you can see the R for right, this is sort of backwards of what you might expect. It's you read an x-ray as if the person is standing there looking at you. So this left hip here has no cartilage, is very collapsed down. And so we talked to her about joint replacement, and ultimately that was the right decision for her. And sorry, so she was actually really complaining that she had to give up golf and travel, and so this is why ultimately we felt that joint replacement was right for her at this point. She was waking at night with pain. So this is the hip replacement, and you all got to see what that looks like. This was done through an anterior approach. So here's her new titanium socket that's growing into the bone, that new stem that's going to grow into the bone, and there's the new ball head. And you can see we've got her legs back to being the same length. And that new joint moves very well. And she actually sent me an email about 3 weeks out from surgery saying how miraculous it was that for the first time in over a year, she was not taking any narcotics, and how much more alive and awake she felt, and how grateful she was. So that was a really nice option for her. This is another patient who's in his mid-60s. This is a male. He's had pain in both knees for many years. He's been told, especially by his spouse, that he's getting more bow-legged. He's also being prevented from doing the things he likes to do, notably golfing. He likes to golf a lot. And he tried some injection in his knees. He tried PT. And these are his two knees. And you can see here again, this loss of cartilage. So there should be good cartilage between the bones. And when there's not, that's when it's time for to consider a joint replacement. And so he, on the medial side here of his left knee and the medial side of his right knee, had lost all of his cartilage there. And so we talked about it. And ultimately, joint replacement was right for him. And so these are his new knees. We did them about 6 weeks apart. He recovered so quickly from the first. He initially had planned to wait a year, but he came back in and said, gosh, that was the best thing I ever did. Let's do the other side. And so he got his other side done just a few weeks later. And then after surgery, he was off all walking aids by 2 weeks. He was down to no pain medicines, just taking ibuprofen only. He actually was back on the golf course at 2 weeks, which is not everybody is that aggressive, but it was really important to him. And so he got back on the golf course pretty quickly, and he was getting ready for a trip to Europe with his wife. And this was about a year and a half ago. So this is pre-COVID. Unfortunately, right now, a trip to Europe is a little hard to do, but he was pretty excited about that. This was a while back. So in summary, I really think it's important to emphasize you want to choose a surgeon in a hospital that have a high volume and a good track record. I can't emphasize that enough. And then again, you want to avoid these sort of gimmicks and fads that don't have much evidence, and really go with these tried and true techniques that have been shown to work very well for patients over years and years and years. You should plan to recover well at home, and the less time in the hospital for you, the better, for many reasons. And after 6 weeks, your joint will be well healed, and it's time to get back to living your life. So this was big news this week, and I just wanted to share this. Some of you may have seen this on the news, but I'm sure many of you recognize Christy Brinkley here. This is from her Instagram, and she said, "New year, new hip," and she's talking about her hip replacement. She said something here that I thought was really nice to share. She said, "I'm writing all this to say, if you've been putting off something that could improve your well-being, but you've hesitated out of some sort of fear, I suggest learn as much as you can." So there you go. That education part is really important. Learn as much as you can about the process and the results and the expectations. And she said, "I found the best doctor for my circumstances, and voila. I can't tell you how happy I am to have done this. Now I can focus on getting back in shape and rebuilding my strength. Never too old to get hip." So, Christy Brinkley may not be our standard patient, but her experience is actually very common. Most of my patients say this. They say, "Oh my gosh, this was life-changing for me. I wish I had not waited." And here she is, just 6 weeks out from surgery. She's getting ready to do a dive. Now, again, I, I hope she's waited the full 6 weeks because we don't want our patients to get underwater until that 6-week time point. But so that's the end of my presentation. I'm happy to take any questions. I'm sure there are some in the Q&A. And Marcia, if you want to help facilitate that, I'm happy to answer anything.
Yeah, that was great. Thank you so much. I appreciate that. If you want to go ahead and turn off your screen sharing now, we had lots of great questions that came in. One of the first questions we had is, how long will your muscles be sore after you have a hip replacement? Like, how long is that incision going to hurt?
Yeah, the muscle soreness goes away within a few, I'd say the worst of it goes away actually 2 to 3 days after surgery. So many people by 2 to 3 days feel much, much, much better. And thankfully with our regional anesthesia, actually those first couple days are not even that uncomfortable. Many of our patients are at home at that point. But the muscle pain can last, and typically little aches and pains here and there for up to a year out from surgery. But I tell people most of my patients are fully recovered or 90% recovered by that 6-week time point. So most of that soft tissue healing happens in that first few weeks, but then it can take up to a full year to complete that 100% recovery.
Okay, great. I know someone who had a hip replacement, and the little bit of muscle pain was nothing compared to the pain that was in their joints that was instantly gone. So it seems like it's don't put it off is kind of the message that the person I know said. So
yeah, it's not uncommon. I was just going to add to that, Marcia. Sorry, it's not uncommon for me to see patients in the recovery room or the next morning, and they already say, "I feel better than before surgery." So yeah. That's pretty amazing when you think of what we're doing in there in terms of basically breaking their bones, with power tools and replacing them. So it's pretty incredible how quickly people's bodies respond.
I agree. Well, that kind of really leads to the next question that was submitted. Someone said that they had a friend who waited till they were about 90 to go get a new hip, but then it was too late for that person. So what are the trade-offs versus, like, how do you know when is the time, I guess, is kind of their question.
Yeah, it's a good question, and probably one of the most common questions I get. So the way I look at that is there's no set time limit when it's too early, when it's too late. I actually have 90-year-olds that are as active as some of my 50-year-old patients, and then I have 50-year-olds who are less active than some of my 70-year-old patients. So it sort of goes all over the place. What I really try and use as a good indicator when I meet patients is, how much is this impacting your quality of life? Are you giving up things that are important to you because of your hip or your knee? And for instance, if it's really meaningful to you to be able to travel, and again, I know travel is hard right now, but hopefully in a year or a few months this will be different. And you find that you're giving up trips because you say, well, I was going to go with my spouse to somewhere and we were going to hike the Grand Canyon or something, but I decided not to do it because my knee was bothering me. That's the time I think is reasonable to start thinking about joint replacement, because thankfully our prosthetic joints now can last 15 to 20 to 25 to 30 years with some hips. So, I think once your life is really being shut down, it's a good time to start thinking about it. And sometimes we can avoid surgery, and so it's good to come in and talk to the surgeon. But there's no reason to wait just for the sake of waiting, because we hear many stories like that. People say, "Oh my gosh, I waited too long," and then they can't do it. So it's good to go have a conversation with your orthopedist if you're at that stage.
Okay, thank you. One of the next questions that came in is, how do the new techniques that you kind of mentioned, how do they work on a revision? Can you talk a little bit more about revisions?
Yeah, it's interesting. We applied a lot of these things broadly. We just sort of said, hey, whatever we do for our primaries, we're going to try and do the same thing for our revisions. And historically, revision surgeries have been thought to be really difficult in terms of recovery. We actually found a lot of the same benefit applied in our revision surgery patients. So our length of stay for our revision surgery patients is also down to about 1 to 2 days. People are having less people are taking no more narcotic pain medicines with revision surgeries than they are with primary surgery. So now, not all revisions are equal, and some are more involved than others. But for many of our revision patients, they've had the same benefit from these things as our primary patients. So many of the same things apply. But again, everything is on a case-by-case basis. So it's good to discuss it with the surgeon.
Okay. Does taking an immunosuppressant for an autoimmune disease increase your risk of infection if you've already had a hip replacement?
It does, yes. Unfortunately, there's no way around that. When you are chronically immune suppressed, you're always at risk for an infection. So the majority of people that get infections are people who have immune suppression for some reason, whether it's a medicine they take or diabetes or rheumatoid arthritis. So it is always a risk. That being said, thankfully, infection rates are very low. They're about 1%, 1 to 2% nationally. A little bit higher in chronically immune suppressed. But again, that's one of those good times to talk to your surgeon and say, hey, what are my relative risks and benefits here? And there may be certain things that can be done, modifications to the medication regimen or something to help improve that. But it's a good reason to talk with your surgeon.
Okay, we had another kind of question that came in about infections that's related to that, I guess. So someone said, I've received a total knee replacement and contracted a life-threatening infection, requiring a second operation to clean out the wound and replace the knee again. What could have caused that infection?
Yeah, sometimes we have a pretty good idea and sometimes we don't know. Often infections can actually come from within your own bloodstream. So for a few weeks after the operation, actually for about 6 months after the operation, there's increased blood flow to the joint. And so if you get an infection elsewhere in your body and it goes into your blood and you get what we call bacteremic, that can then go and go into the joint and damage the joint and set up shop in the joint. So it's impossible to know with certainty where that infection came from, but often, depending on what bacteria it is, we can have a pretty good idea. But yeah, unfortunately, those things do happen, and that's why we emphasize that surgery is a good discussion to have. It's not right for everybody, but thankfully here at Shands, as I mentioned, we were recognized by Medicare as a national leader in terms of infection rate. So we actually gave a presentation for about 300 health systems on how to minimize infection risk. And so there are some good tricks and techniques that we've used at, being friendly to the soft tissue, being careful with minimizing transfusions, optimizing people ahead of time. Many of those things can cut down that risk. But yeah, unfortunately, that story from that patient is not terribly uncommon. We do hear those things, and being a tertiary care center, we see a lot of those patients, but thankfully we're able to restore function and pain-free living for most of those patients.
Also, another question that came in, what are some of the other comorbidities that puts you more at risk or maybe wouldn't allow you to have a knee replacement?
Probably the ones we see most often are people with uncontrolled diabetes. So people who are diagnosed with diabetes and for whatever reason have had a hard time getting their sugars in good shape. People with severe heart disease where the heart just doesn't pump as well as it used to. And many of those patients can ultimately have joint replacement, but they need to be optimized. There are very few things that we say, nope, you'll never have a knee replacement or a hip replacement. It just often means that we need to fine tune some of your risk factors. Weight is a big one. So many of our patients are obese. That's a national problem. And so we don't say, no, you can't have a joint replacement. We just say, hey, what can we do to help bring your weight down a bit so that you're safer? And ultimately, it's about weighing risk and benefit. So for someone, it might be that, hey, we think the benefit of this outweighs the risk, even if you're high risk, and we proceed with the joint replacement. We try and minimize that, but we work together with the patient to try and make them sort of optimize. So there's very few things that we just say no. It's usually not yet. Let's figure out how we can team with you to get you better.
Okay. So talking just broadly about a joint replacement, someone asked a question about shoulder replacement. What is the expected recovery for shoulder replacement? What's the recovery time for that?
Yeah, I'm not a shoulder surgeon, so my expertise is a little limited in that regard. But my understanding from my partners who do that is that it's similar to hip and knee replacement, about 6 weeks of time to get fully healed in terms of the soft tissue. But it can take up to a year with shoulder replacement as well to let everything finish healing. But pretty similar time frame is my understanding. But if somebody has a question about that, we have a lot of good shoulder surgeons here, and so I could help get them plugged in with one of my partners who specializes in that.
Great. Okay. Let's see. So I think you addressed this, but you might have called it something slightly different. But I got a couple questions about minimally invasive knee replacement surgery. Is that what you were describing, or is that something different?
Yeah, so minimally invasive is a term that is used by a lot of different people to mean a lot of different things. I think what we do here now is muscle friendly. Minimally invasive is probably a good term for it, but depending on who you talk to, it means something else. There's a kind of knee replacement where they go in through the outside of the knee, through the lateral side of the knee, and that's become very popular locally. But unfortunately, we've seen a lot of complications from that. And so I don't personally recommend that approach because it has a high failure rate. But there are ways that we do the operation that are very minimally invasive in terms of how much damage to muscle and tissue. And I think our patients get moving in many cases even faster than that sort of lateral approach that's become very popular in this area.
Okay, I had several questions about how long do joint replacements last, and does that vary by age group?
Yeah, it does actually. So on average, a knee replacement lasts about 10 to 15 years. And on average, a hip replacement, we think, with modern plastic lasts about 20 to 25 years. But there is age variation. So for a 70-year-old, we would hope it would last them in either case for the rest of their life. For a 50-year-old, because 50-year-olds traditionally are more active than 70-year-olds, they may still be working, they may still have a lot more demands on their hip and knee. The general expectancy is a little less. But that being said, there's tremendous variability. I've seen patients who had their knee done when they were in their 30s for whatever reason, and 25 years later, their knee is still in good functioning condition. So there are exceptions to everybody, but on average, yes, younger patients, they don't last quite as long because of a higher demand and activity level.
Okay, I had another question that asked about the if you have pain after 2 years of having a hip replacement, what would that suggest possibly?
Yeah, it's really it's hard to say exactly what could be causing that. There's a lot of different things that can cause that. Some from inside the hip, some that are not related to the hip. the things that we always worry about would be an infection or that something has come loose with the prosthesis. The best move if you're having pain and you're not satisfied 2 years out from the hip replacement is to come in and get checked by one of us because there may be a simple fix, there may be a very complex fix, there may not be a fix, but a discussion with a good orthopedist is the best way to start. And if you're not satisfied at 2 years, you should have a conversation with somebody. So
just call and say, I need someone to look at this. I've had surgery before. Okay.
Absolutely. Great. Yeah. Our team is really good. You call the orthopedic number that I'm sure Marcia will share later, and they can run through a series of questions and get you plugged in with the right provider, and typically within a fairly short period of time.
Okay. Someone asked a question about they've had a hip and knee replacement on the same side. Is bike riding an acceptable thing to do because they were concerned maybe about falls?
Absolutely. Yeah, we love, I encourage my patients to bike ride. Some people like to start with a stationary bike or, something that is sort of fixed to the ground so that they make sure they get comfortable. Yeah, bike riding is a great activity because it's low stress on the joint. Sure. Obviously, you want to be careful. You don't want to fall, but that sort of goes for anyone. Any of our patients we want to avoid fall. But these joints are not necessarily at increased risk of a fracture compared to your own bone. So even if you're a regular 55-year-old who wants to ride a bike, you got to be careful about a fall. The same as if you're a 55-year-old who has a hip replacement. So, but yeah, we encourage that kind of activity. We like to see our patients doing those sorts of things.
All right. Someone asked, does everyone on your staff incorporate the new practices just as you do?
For the most part, yes. Again, there are certain case-by-case exceptions. Not all of us do the same approach for hip replacement. So about half of us like the anterior approach, about half of us do not do it. Ultimately what it comes down to is, as I said, far and away the most important thing is a high volume center and a high volume surgeon. So, and all of our surgeons here fall into that category. And obviously UF Health is a high volume center. We have really good results. So I would endorse every one of my partners to any patient or any potential patient on the line. So it just is, again, I hate to keep hitting this theme, but it's a good conversation to have with the surgeon because if you believe in something, they can tell you why or why not. If they don't, and tell you why they think something might be right for you. But everybody here has really excellent outcomes.
Okay, I have a question that says, I have osteoporosis in one hip. I have pain from that and it's sporadic, but would a hip replacement work with osteoporosis?
Yeah, we do osteoporosis hip replacements, not infrequently. So yes, you can absolutely have a hip replacement. Now, that being said, we would need to make sure that a hip replacement would be the right surgery for you to help get rid of the pain. So having osteoporosis does not preclude you from a hip replacement, but again, you would want to talk to the surgeon, talk to me or one of my partners, have us review your x-rays, have us examine you and make sure that we think a hip replacement is a good choice for you for all those reasons. But yes, even with osteoporosis, we can have very successful outcomes.
I got a couple questions about, I go to the dentist and I've had a hip replacement or a knee replacement. Do I still have to take antibiotics because I'm getting mixed answers? Yeah,
there are mixed answers. That's very true. So with antibiotics and dental procedures, the American Dental Association and the American Academy of Orthopedic Surgeons have put out a position statement saying that there is no evidence that you need antibiotics. But many dentists still recommend it and many orthopedic surgeons still recommend it. So what I do is I recommend no dental work for 6 months after the joint replacement because of that time point where people have that extra blood flow. And when you go to the dentist, you can get bacteria in your blood for a short period of time. And so I recommend no dental work for 6 months. But then after that, I don't ask my patients to take antibiotics. But there are certain patients who may be high risk and we may do it, or they may be having a high risk procedure at the dentist where we may recommend it. But yeah, the American Dental Association has recommended against it. And that's the approach I take. But again, case by case basis, there may be a reason to do otherwise.
Okay, and you're going to talk with those things periodically when you're visiting with them, because how long do you follow a patient after surgery?
Yeah, so we talk about all this stuff with our patients all the time. And what we typically do is we follow our patients for life. We have an increased frequency of visits in the first year, So we see you typically around, everybody sees folks about 6 weeks out from surgery. We see some of our patients a little earlier, and then we see them again several months after that, around the and again around the 1 year mark, and then again at the 2 year mark. And then after that, there's some variation, but typically we like to keep an eye on you for life. I mean, once we put that joint replacement in you, we want to make sure it's working well. And so we continue to follow our patients as long as they're around and around here, and we're here. So I just saw a patient today who's 5 years out from a joint replacement. So and doing very well, but we like to keep an eye on them and make sure everything's going smoothly.
Perfect. Okay. So I got a question that says, I'm 5 years out from having knee surgery with UF Health Orthopaedics. I'm having problems getting on my knees. Is there exercises I can do to use my knees a little more comfortably? I have trouble doing floor exercises. What would you recommend?
Many of our patients note that, and there's actually something you can do called a kneeling program. And that's a way to essentially train your knees to be able to kneel again. You can actually Google it. So if you're watching at home and after we finish this call, you can jump on Google. It's I think there's a PDF available, but it basically, you start with a pillow folded over in half and kneel on that as long as you can tolerate it, 10-15 minutes. And then you do that for a few days until you get to where you can do that sort of indefinitely. And then you go to the pillow just on its own. And then eventually you go to just being on the floor directly, and just kind of training your body to do that through prolonged exposure, and starting with that pillow is a really effective way to do it. But you should be able to Google it if you want to read more about what I'm talking about.
Okay. I got a question about steroid shots and about stem cell therapy. Are those effective treatments?
Yeah, right now the answer is yes and no. Steroid shots have been shown to offer relief for people with mild to moderate arthritis. It does not fix the underlying problem. It will not repair your cartilage, but it will give you symptomatic relief for a few months. As your arthritis worsens, that gets less effective. Stem cell therapy, unfortunately, has not been shown to work. It's been shown definitively to not work. So I do not recommend stem cell therapy. The American Academy of Orthopedic Surgeons does not recommend stem cell therapy. At some point in the future, it may work. I have been an orthopedic surgeon now for almost 15 years, well, 13 years. And since I started, people have been saying, well, that's a few years away. It's a few years away. And here we are 13 years later, and it's still a few years away. So unfortunately, stem cell therapy has gotten a big following. It's very expensive. It's cash only. And the reason it's cash only is because insurance knows that it doesn't work. So the insurance company would much rather pay a couple $1,000s for stem cells than what it costs to have a knee replacement, which is fairly expensive to the hospital and all the implants and everything. But unfortunately, it just doesn't work. So we hope in the future that will be different. There may be some promising gains happening right now, but at this point, we do not recommend stem cell therapy at this stage.
Okay. When a person has a joint replacement, what kind of method is used to close it? Is it stitches? Is it staples? Is it glue?
It depends. I personally like staples for knees, and I use glue and absorbable stitches for hips. Some of my partners use glue and stitches for knees as well. But there's variation, and both can work very nicely. I like staples for knees because the staples move well with the knee incision, and we like knees to move a lot right away. So that's my personal preference, but each surgeon is a little different, but both, as I showed, can have a really good cosmetic result.
I had a person who said they had a knee replacement with a certain brand name of device. Is it important, they need to have the other knee done, is it important they use the same brand of device for the next knee?
Yeah, that's an interesting question. We often will try and match implants if a patient is very happy with one and that implant is still available. Unfortunately, sometimes these things do come off the market. So depending on how long ago it was, the company may no longer make that knee. And so we can't always make an exact match. But when available, yeah, we do like to do that, but it's not a necessity. I actually have a handful of patients who have two different kinds of knees for various reasons, and they like both of them. And certainly there's no risk to the body, for instance, if there's not going to be a risk of rejection or anything. the materials are all very similar. So it's just a question of whether or not we can match it, and if there's a good reason to or not to. But no, there's no set rule that says you have to. We often do.
And is there any particular type of implant that is better for a medial partial knee replacement?
No, there are many good implants that work well for that problem. There are several on the market that we use here in Gainesville that work well. Again, the key thing there is finding somebody who does it frequently and who has a good track record, because different surgeons find that in their hands certain implants work best, and so you want to go and talk to your surgeon and say, hey, what do you use and why? But the actual implant is much less important than the technique and the experience of the surgeon.
Okay. And do you use a robotic technique, or is this something that's done with the surgical robot?
Yeah, the robot has gained interest and appeal and is being done in certain centers here in Florida. We do not at this point use a robot. We may in the future. I will tell you, I've had the opportunity to at several time points. The data still does not show that it actually helps improve outcomes. So for right now, I put that in the category of a marketing trend. It's a good way to distinguish yourself, is to say, hey, I use this robot. But all the data that has come out has actually shown that it does not improve successful outcomes. So, so in my current hands, because I'm a high volume surgeon, my outcomes are equivalent or better to what the robot makers claim for their outcomes. But if it is shown at some point to improve outcomes, we will certainly use it. And we've been experimenting with bringing one into Shands in the next few months. So that may be something that's different shortly. But as I said, there's no data that supports that it's important for outcomes. But it may be a nice research opportunity or teaching tool. So we may have one here soon.
I had someone who asked a question about, I know someone that received a designer knee, like that was custom made for that person, but they haven't really had good results with it. Could you talk about like the trend of a designer knee versus maybe I got the size 7 implant or something like that?
Yeah, it's funny that that person mentioned that. So the designer knee trend is sort of going away right now because there was one big company that made a lot of these, and unfortunately they were having some early failure problems, and so many surgeons, I think, have gone away from using those kind of implants. I personally don't use that implant. What's remarkable about knee replacement is if you go back 30 or 40 years ago, there may have been 3 sizes. You got a small or a medium or a large. And obviously people's bodies come in more than 3 different shapes and sizes. So, but the companies have responded over time. These big companies that make a lot of these implants and that have had a good track record now have sizing gradations that are down to a couple millimeters apart. And so, and they're all based on MRIs and CT scans of actual patient knees. And so if somebody is in my operating room, I measure their knee and I can put an implant in that's within 1 to 2 millimeters of their native bone size. And so that's a quote off the box or off the shelf implant, but it actually has a better track record than the quote designer implant. So, so for right now, many surgeons are going away from the designer implant because of not as much success as had been hoped.
Okay. Someone asked a question, is there a contraindication for bisphosphonates and this type of surgery?
Many of us will recommend holding bisphosphonates for a period of time around the surgery, but it depends on why you're on them and again, what the risk and benefit is. So if you're somebody who takes them, we would have a discussion with you about how to take them safely around the surgery and when to stop them and when to resume. But yes, we do generally recommend, all things being equal, that people hold on those drugs for a period of time afterwards.
Okay. Someone also shared that they had surgery in 2004 and had to stay in the hospital for a couple days. What is being done that's so different now so that you can send people home the same day? And then that person also went on to talk about like having to stay in the hospital and use a catheter, and what caused that urinary retention issue?
Yeah, some people are just at risk for urinary retention because of their own, the way their bladder is, or the way males in particular get urinary retention often because of a prostate. So sometimes the bladder goes to sleep with anesthesia and is slow to wake up. What we have done to avoid that is we don't use catheters anymore. So putting in a catheter actually increases your risk of needing a catheter. So for most of our patients, they get no urinary catheter and they never need one. Males who have a known history of prostatic hyperplasia or hypertrophy, BPH, we have them take their medications that they use for that, and that helps minimize that risk. But sometimes it happens. It happens rarely, but it does happen. And so on occasion, I'd say maybe once every 6 months, I have a patient who has to leave the hospital with a catheter and then come back and get it taken out a week later. But that's pretty rare. The things that we've done to improve people being able to go home, probably the biggest thing has been improving the not needing transfusions. We have less blood loss now because we have a medication that we use that helps minimize blood loss. And also I think our surgical techniques have improved a bit to minimize blood loss. But by not needing to give transfusions, people just heal more quickly. They have more energy. They get up and get moving more quickly. And then also not using as much narcotic. We have other ways to help people be comfortable. So if you're not using a bunch of narcotic, you also have more energy and you're more awake and you're not constipated and you just feel better. So people get moving a little more quickly. So I think between those things, the regional anesthesia program where people are very comfortable, they don't need to be hooked up to an IV narcotic. They're just able and not using a urinary catheter and not getting a blood transfusion. People just get up and they get moving. And we have, as I said, we have people in the PACU that are physical therapists that are ready to be right there and get you moving. And that makes a huge difference. If you're in the recovery room and you say, okay, I feel all right, we want to get you up and get you walking. And I think that helps build confidence for the patient and their family. And then they know they can be at home. So I think those are probably the biggest things that we've done, but it's multifactorial and it's continued to improve. When I started here 5 years ago, we were keeping people a couple days in the hospital. But as I said, now we've just slowly seen the sort of creep down in that amount of time, and people have been really happy with, our patients have been really happy with it.
That's great. It's amazing they can do that right there in the recovery room. So,
yeah.
Well, that's all the questions that we have. Is there anything else you'd like to add? All right. I think we're good. So I appreciate your time today. I appreciate all the knowledge that you've shared with us. And thank you guys for tuning in today. Appreciate it.
Thank you, Marcia.